So today's topic is the talk on which I am talking about is the GENU valgus and its management principles. I have taken the case scenarios like about the ages and what kind different patients in which we use the different implants. So moving to the GENU valgus, valgus alignment is an inward angulation of the extremity in the coronal plane, what we usually know, and this is the fact, with the tibia laterally deviated in relation to the femur. But it is not the case with all the patients. Sometimes we do have sagittal plane component as well as the rotational component. And when we have the sagittal plane component and the rotational component, then our work becomes difficult. So we may face these questions. Every valgus at the knee is considered to be deformity. I would say no. It depends on age and the degree of valgus as well. Who is contributing to the deformity? It is a femur, tibia, or the joint. Every valgus has same treatment? No, it depends on age, degree of valgus, association of sagittal, rotational component, and also the limb length discrepancy. So we need to consider all these facts before moving forward towards our management protocol or using the which kind of fixation is we are going to use. So Venka and colleagues, they have plotted this graph and they have said that usually it's a phenomenon that up to 1 year, 1.5 to 2 years of age, it's the physiological varus, which moves towards the valgus. And at around 4 years, the valgus is maximum, which settles down at around 7 or 8 degree of the normal valgus at around 7 or 8 years. So giving to the etiology has there are different etiologies: physiological valgus, pathological valgus. In pathological valgus, there are the cases of the trauma, tumor, infection, metabolic, neuromuscular as well, sometimes the skeletal dysplasias and the syndromic associations too. So we need to consider some red flag signs when we have the asymmetric involvement, when we have the short stature, and when we have the limb length discrepancy. Then if we find these things, then our work is not simple. So moving forward about the patient evaluation, clinical evaluation, as well as imaging, what actually is required, also augmented with the laboratory diagnosis. So in case of clinical evaluation, we need to evaluate about the angular deformities, about the rotational profile, and both. And with respect to imaging, we need to do a lot of other things as well. So these patients usually present with the adduction at the hip, knees touching each other, widely spaced angles, and medial thrust. This is the usual case of a GENU valgus patient having deformity in the coronal plane. But if the patient is having deformity in rotational as well as sagittal plane, then some additional features may also add. So we need to see the movement or the range of motion. We need to assess the site of deformity, either the femur or the tibia. This is the simple clinical assessment method, just to see whether the deformity is in femur or in the tibia. We need to angular profile measurements, tibiofemoral angle and the intermalleolar distances. This is how we measure the tibiofemoral angle. This is how we measure the intermalleolar distance by making this patient to stand. Rotational profile, I always go for the clinical examination with respect to the rotational profile because sometimes we miss these things. Clinical examination in foot progression angle, thigh foot angle. So foot progression angle, this is what we call, and thereafter the thigh foot angle, we need to consider it too, just to see the torsion at the tibia. Then about the rotations at the hip, just to exclude that whether the GENU valgus is contributed or some compensatory mechanism at the hip or not. And we need to also assess the assessment of joint laxity. We need to also assess the Q angle assessment for the patellar malalignment. Now moving to the next important thing, imaging. So whenever the patient comes to us with a GENU valgus deformity, we will send him for the X-ray, just go and get the X-ray done. What radiologist is doing is what we order, that full length X-ray extending from the ASIS to the ankle joint, AP standing view and the lateral view. This is what the radiologist done. And this is what we have interpreted, that patient is having a deformity on the left side and the right side seems to be normal on a macular vision. But this is what actually the patient she has the deformity on bilateral lower limb, but our imaging is not giving that impression. So our imaging should be appropriate. We need to position the patient properly so that we can get the good X-ray. Just to get the proper AP view and the proper lateral view, we need to position the patient in a proper way. If we position the patient in a proper way by making him stand for the AP view, patella facing forward, knees in full extension, and imaging, then our imaging will be okay. This is the actual full length view, AP view, and these are the actual lateral views that we require for further assessment of deformity, whether it is in the femur or in the tibia, or how much deformity is. This is how we actually move forward, map the ABC. This is what Dr. Drawer has told. This is what other Ilizarov surgeons follow, that measure the mechanical axis deviation, analyze the joint angles, pick the deformed bone, whether it is femur or tibia, find out the apex of the deformity, plan out the bone cut, and then just pick out the correction method, either by acute or the gradual correction. But it's not that much simple. So we need to memorize this, these angles, LDFA, MPTA, as well as the sagittal plane. So we do have the different options for fixations, either by the acute correction or by the gradual correction methods, like using guided growth plates, using 6-axis correction systems, using Ilizarov. I personally prefer K-wires, absolute no, because they can lead to a lot of problems. So out of these options, what we choose, what we should not, it depends on the age and the degree of deformity. So with the help of cases, I would represent these things. My first case was the 12-year-old boy with bilateral idiopathic GENU valgus, having tibiofemoral angle of 20 degree, intermalleolar distance of 16 centimeters, Q angle of 15 degree without any rotational, with normal range of motion. So my child was a 12-year-old boy. He was basically having an immature skeleton, having no rotational as well as the sagittal component to the deformity. So it was clean-cut GENU valgus. So I have chosen the guided growth. I did the imaging part. So I have chosen the guided growth for this patient, and this was the after full correction was achieved. So I have chosen the guided growth because the child was having the immature skeleton. He was having the potential to correct himself if we guide the growth. Now, these are the final follow-up pics of that child. Now, moving to the case 2. She was the 18-year-old girl with GENU valgus deformity. She was also having no sagittal and coronal component. So I decided to put acute correction with corrective osteotomy and fixation with plate. I cannot use the guided growth in this. She is a skeletally mature child. And so I was not using the Ilizarov or the 6-axis correction systems. So I have decided for doing acute correction. And with respect to the pre-op imaging, I did this full length X-ray extending from the ASIS to the ankle joint, and find both the mechanical axis are outside the third Steven zone. So what I find that if the child is around 18 years or 17 years old, then lateral femoral condyle plates fit very well. But if the child is less, about 15 or 14, then I prefer to use the medial tibia plates. These fit very well to the actual contour of the femur. This is what I actually do in some of my patients. I usually use the proximal tibia plates. Now, I stage this procedure. I have corrected the first one leg at a time because of otherwise the patient will be bedridden. So we have corrected the right leg, left leg first. We have used the plate for fixation, and we did the dome osteotomy. This was the X-ray after correction. In the next stage, we did the same thing. After 6 months, we have gone for the corrective osteotomy by the dome osteotomy and fixation with the same plate. And this was the child after full correction was achieved. Now, moving to the case 3. She was a 17-year-old girl having the GENU valgus of right side. But this child had sagittal plane as well as the rotational component. Also the limb length discrepancy, as you can very well see. So I did the pre-op imaging, and in the imaging too, you can find out that there is a limb length discrepancy present. There is a valgus of right side with shortening, and as well as the rotational component is not that much obvious on the preoperative images, but clinically she was having the rotational component as well. So we have planned it for 6-axis correction system. This was the for these are the follow-up images during the correction. So we have used the 6-axis correction system in this child, as the child was having the limb length discrepancy as well as the other rotational and coronal plane malalignment as well. So we need to correct everything at a time. So we have decided to use the 6-axis correction system. We cannot use the plate. We cannot acutely correct as it was having the rotational component. We cannot use the guided growth as she was a skeletally matured side. So we have decided to use the 6-axis correction system. This was the final follow-up picture. The mechanical axis is well aligned. This is the lateral image. And these are the final follow-up pics of that child. She is a medical student. Just now she is pursuing her MBBS. Now moving to the case 4. She was a 13-year-old girl with GENU valgus deformity, usually bilateral. These were the pre-op images of that child. She was having the bilateral GENU valgus deformity. The deformity was mainly in the distal femur. So as she was a 13-year-old child, as she is a girl, then definitely that it's an adolescent child. And I'm not sure that how much growth she is having. So I did the CT scan, found that there was a fusion of growth plates. So we have decided that we will go for Ilizarov, and we have applied the Ilizarov, and we did the corrective osteotomy here, and with the gradual correction. This was the follow-up X-ray, and the child deformity is quite corrected. She is still in follow-up. So my take-home message is, keeping in mind about all the possible causes of the given condition, try to reach out the provisional diagnosis. Know how to take the full length X-rays. These are very important. Learn how to assess the deformity clinically as well as radiologically. Don't miss to examine the rotational as well as the ligamentous laxity. Judiciously use the different methods of management, be it guided growth and corrective osteotomy, either by the acute correction or by the gradual correction. No deformity is too difficult to deal with if we are aware of management principles and we are well conversant with our galaxy of armamentarium. And before concluding, I would like to invite you all for our AssamiCon 2022, which is to be held on 17th, 19th June 2022 in Pune, Maharashtra. Dr. Ruta Kulkarni, who is the current president of our association, is the organizing chairman of AssamiCon 2022. I invite you all. We have a basic workshop on 17th, including all lectures from the renowned faculties. We are also having the workshop on 17th on the depth fixator in pediatric use. Thank you.